everyone. So everyone, please enjoy the session. And if you have any query, so please put it into the query box. So please, ma'am.
Thank you very much for that very kind introduction of me to all of you. Very good evening to all of you present here. At the outset, I'd like to thank the Society of Cardiac Nurses India and the Nursing Teachers Association of India for having me with you all on this webinar series. And indeed, I am very privileged to be here amongst you to speak little about midwifery, which is my passion. Let's get into the presentation. Let me share my screen. Yeah, I hope it's visible.
Yes, ma'am, it's visible. We can make it slideshow.
Okay. Yeah, the topic that has been allotted to me for this today's webinar is midwifery mastery, evidence-based practices for optimal outcomes. Um, so basically, I'd like to share with you all what does an optimal outcome means. In any situation, in any given situation, an optimal outcome is the best possible result that we can get out of any kind of situation. And it means that out of the given situation, we are having maximum number of benefits with minimum number of risks or drawbacks. Now, talking about optimal outcomes in midwifery, generally we speak about four things. That is, one, having or giving birth to a healthy baby by the mother, and the baby is usually born vaginally with minimal interventions. That is, there is no need of any instrumental births or things like that. So minimal interventions. The mother, after giving birth to the baby, has a positive birth experience, which means to say that the mother is very happy about the entire experience and she is satisfied with the care that has been provided to her throughout the pregnancy and birth, that is having a positive birth experience. And of course, it should not be having any complications, either in the baby or in the mother. So when we have these four things attained at the end of the continuum of pregnancy and birth, we call that as an optimal outcome in midwifery. Now, coming to the different, before we get into the evidence-based practices that we usually use in midwifery, I'd like all of you to understand what is the basic way of providing care to mothers who are pregnant. Right. So normally we have different models of care that is being used to provide care to the pregnant women. First, there are many models, but basically I've picked up two models which are very commonly used. So the first one is the biomedical model, which is also the obstetric model. Here, the head of the model or the person who carries forward the care in this model is the obstetrician. And for an obstetrician who is a trained person in dealing with pregnancy and pregnancy related complications, pregnancy usually they look at it as not a physiological process, but it is something like any other disease form, right? And usually they are supposed to be dealing with complicated pregnancies. So according to World Health Organization, only 13% of the women who are pregnant need such kind of care. And the remaining 87% of women who are like having low risk normal pregnancies, see, since pregnancy is a physiological event that happens in a woman's life, right? So since it is a very normal and physiological event, the remaining 87% of the pregnant women need not take their care or services from this obstetrical model. Rather, the World Health Organization says that such kind of low risk mothers can be cared by midwife-led care. So the next model of care that we are coming up with nowadays is midwife-led care. And in that we have different kinds of models, but let us very briefly talk about continuity of carer model in this particular uh, genre of care. So in continuity of carer model, the pregnant woman receives her care throughout the continuum of pregnancy, that is the prenatal, antenatal, intranatal, and the postnatal care from one lead midwife. This lead midwife is supported because it is not possible, humanly possible, for one midwife to attend to the woman all through the 9 months or the 40 weeks of pregnancy. So it is not really possible. So they are usually backed up with a buddy midwives. So they act and work in teams and they provide continuous care to this woman. So this kind of initiative actually was designed and it was tested under a program which is called as Better Births Initiative in Britain. And this kind of initiative and this kind of model of care was associated with a lot of benefits both for the mother, babies, as well as midwives. So let us have a look at what are the benefits of having a midwife leading the care for the pregnant woman. So this kind of model, when it is used appropriately, it has shown lower percentage of unplanned cesarean section, lower percentage of postpartum anemia in the mother, and it has also shown statistically lower rates of admission of neonates into NICUs. And the women who have delivered under such kind of care have had greater maternal satisfaction. And of course, since the care was provided by midwives, it was also felt that it was a cost-effective model. Apart from these advantages, the research also says that when a woman is cared under midwifery model of care, there are 15% less chances of likely of using the epidural analgesia, 16% less likely to lose their babies, and 16% less likely to have an episiotomy. Episiotomies, you know, are a very painful procedure. Even though it is usually considered as a minor procedure, it is a very painful procedure, as well as a lot of women fear they land into tocophobia because of this procedure. So when a woman is cared under a midwife's care, or when she is under midwife's care, there is 16% less likeliness of her having an episiotomy. Apart from that, 19% less likely to lose their babies before 24 weeks of pregnancy. So these are some of the benefits. And moreover, women who have been cared by midwives in their pregnancies, there is 7 times more likeliness of them returning back to the same midwife. So that is the power of the midwife-led care, because there is a lot of communication, interaction, sharing of experiences, and support that goes on in midwifery model of care. So obviously, such kind of model of care is going to give us a lot of optimal benefits, of we can say optimal outcomes. Then now we have understood that midwifery care, when actually provided in the way it has to be provided, definitely brings about a lot of optimal outcomes. Now, how do we facilitate these optimal outcomes in midwifery? So let's turn to some evidences and see how we can attain this optimal outcomes. So I have classified these optimal outcomes into 4 categories again: evidence-based preconception care, antenatal, intranatal, and postnatal care. So let us go through each one of them. And I'm not going to focus a lot on the routine practices, but I will definitely speak about some routine practices which are found to be very beneficial. Now, let's talk about the preconception care. All of you know what preconception care is. It is provision of care that is given not just for the woman, but also for the husband or the partner So basically, preconception care has shown to reduce the risks of adverse birth outcomes, and a lot of preventive measures are used, and diagnoses are made uh, for any abnormalities that can happen. So that is basically preconception care. The American College of Obstetrics and Gynecologists, when speaking about preconception care, they say that a lot of importance is given to the period of pregnancy, that is the antenatal period, because we bounce and fill the mother with a lot of information as to what to do, what not to do, what to eat, and all these things in instructions are given to the mother in the antenatal period. But we always forget, and they say little attention is given to the opportunities of prevention before pregnancy, which is the preconception time. So that is the importance. So when a woman and her husband are targeted and educated, and diagnosed if there are any abnormalities, and they are educated in making informed decisions, the outcomes of pregnancy are going to be very good. So, one of the studies that have been done shows that there are a lot of barriers that are existing for the couples, both the woman and her partner, to access this preconception care. And one of the important barrier that has been identified is lack of awareness that something like a preconceptional health care exists. Right. Of course, many educated people nowadays, especially residing in the urban areas, are now aware of this. But a lot of women coming from the rural areas and semi-rural, semi-urban areas still lack information about these things. So that is where we are losing in targeting them to access preconceptional care. Now, what are some of the evidence-based preconceptional care strategies that give us optimal birth outcomes? So again, we have 4 categories given in this. First, strategies are health promotion strategies. The next one is risk assessment, screening and management strategies, genetic counseling, and of course, family planning. Let us have a look at each one of these in detail. So under health promotion, we give when a woman and her partner comes to access the preconceptional care, a lot of information is given to them, and basically they are educated about healthy life practices, what to eat, what not to eat, and especially maintaining healthy weight. This has become a major issue now, especially in the urban areas. A recent survey, NFHS survey, has shown that 23% of Indian women are either overweight or obese, and 40% of women in the age group of 30 to 45. Nowadays, since the pregnancies are all delayed, most of the women are coming for pregnancies are after 30. So in that category of women also, we see a lot of obesity. And all of us know that obesity increases the risks of many complications like spontaneous abortions, gestational diabetes, PIH, cesarean births, congenital anomalies, IUGR, and even intrauterine fetal deaths. So that is one research saying. So here we encourage the women and the husband as well to maintain a healthy weight by following healthy lifestyle. And apart from that, quitting smoking and alcohol. Now, all of us may think that this might not be a real big problem in our country, but it is surprising to see that almost 14.2% of Indian women use tobacco, both in smoking and non-smoking form. This is according to the Global Adult Tobacco Survey done in 2016-17. And apart from that, our NFHS survey also says that 9% of women and girls aged 15 or older in India have used some form of tobacco, right? So this is showing us that tobacco usage even though we do not realize it is there. And alarmingly, it is increasing, especially in the urban areas as well, with the Western culture seeping in. Lot of girls and young ladies are having smoking as their habit. So smoking, it leads to spontaneous abortion, prematurity, IUGR, premature rupture of membranes, abruption of placenta, and placenta previa. And another important aspect that has to be dealt in the pre-conceptional care is talking to women about alcohol consumption. A lot of, especially we nurses and nursing students, when we tell them to ask whether the mother is actually having these habits of smoking and alcoholism, they shy away because they think it is not an existing habit or a reality. But the NFHS survey says that 1.3% of Indian women actually consume alcohol, and it is also increasing. And alcohol decreases fertility, it increases the risk of having miscarriage, leads to fetal alcohol syndrome and low birth weight babies. So the idea of presenting this information is that when these risk-taking risk-taking behaviors are existing, the outcomes of the pregnancy are going to be severely affected. So our part is to educate these couple or the women to abstain from such risk-taking behaviors. Right? Now, that's about the risk-taking behaviors. And when a woman comes for, sorry, let me go. For a preconceptional counseling, we have to basically talk to her. Of course, this is not a very new finding, but it is a very, very important thing given that the rate of, neurological defects and defects related to the psychology and understanding, like, ADHS, all such things are increasing. Studies have found that there is a strong relationship between consuming folic acid in the pre-pregnant or the preconceptional period. So as projected, a survey that has been done across 10 states in India has documented poor consumption of folic acid. Folic acid is, as you all know, it is naturally available in the greens and fresh fruit and vegetables. But the consumption of the greens and the fresh fruit vegetables is not adequate enough in our women to supplement the folate intake. So that is where we are going in for supplementation. So 0.4 mg or 400 mcg of folic acid is advised for the women from 12 weeks before they actually plan to have their conception into 12 weeks into the pregnancy. So this research has shown to reduce the rates of congenital abnormalities, particularly the neural tube defects in the newborns. Another alarming situation that is happening in our country is the rapid increase of thyroid conditions. A lot of pregnant women who are coming to our OPs, I should say, when we test their thyroid profile, most of them, and maybe around 10 to 20% of the mothers that we see in our OPDs are coming up with thyroid abnormalities. But the statistics say nearly 12 to 13%, but I think the percentage is increasing. So thyroid abnormality, especially hypothyroidism, is increasing in our Indian women. And if it is not diagnosed and treated, it is going to lead to spontaneous abortions, preeclampsia, abruption, IUGR, and even fetal death. So early identification and treatment of thyroid disorders also is important. Then coming to the diabetes, India has, as you all know, is the diabetic capital of the world. And it is also increasing among our young women, especially those women who are living in slums. The reason are not known, but it is been observed that it is prevalent mostly in the slums and also in the urban areas. And gestational diabetes affects almost 11 to 12% of pregnant women in our country. And this can be managed with the diet, exercise, and drugs. Earlier, only insulin used to be used to control if at all drugs were needed, but now metformin and glibenclamide also is being put to use. But this usage of this oral hypoglycemic is avoided in the first trimester because it can lead to some congenital defects in the baby. The next important pre-existing condition that we need to think about is certainly hypertension. Again, hypertension is on raise, especially in the urban young women. And if the mother or the woman is already a known hypertensive, ACE inhibitors and thiazide diuretics should be avoided, especially in the first and second trimester. Calcium channel blockers can safely be used. So the research says that it is safe to use calcium channel blockers in the first and second trimesters to control pre-existing hypertension or even uncontrolled PIH, right? And if it is not treated, it again is going to take us into the defects, congenital defects, and oligohydramnias can be seen in the mother, again leading to not very good optimal results. Now, genetic counseling, this has become very, very important, even though this has been existing. A lot of genetic counseling is needed at this time because especially men and women working in computer-based jobs where they are exposed to a lot of radiation and all. This also is important to screen for any pre-existing abnormalities in the babies. I think this also is in the last 2 months, I have come across 2 families with kids who have had some kind of congenital abnormalities and genetic disorders, because of which they are suffering from very grave illnesses in their early infancy. Right. So for this, prenatal testing is important, helping the partner and the woman understand the implications if they are having any such genetic conditions for the baby. And if pregnancy has already occurred and the diagnosis has been made late, preparing the parents for receiving and rearing the child with special needs becomes important. But if timely genetic counseling has been done, tests have been done, we can expect a very good optimal outcome out of the pregnancy, because the pregnancy will be managed based on the weighing of risks and benefits. Now, family planning, educating regarding the choices in family planning also has become. Recently, I've heard one incident, I've come across an incident where this lady, she was married just for 3 weeks and she tested positive for pregnancy. Now, her husband was very annoyed because he was not expecting the wife to be pregnant, and then he expressed doubts whether the pregnancy is because of their marriage. So, unfortunately, the girl was in her ovulation period when the marriage has happened, and she conceived immediately after the marriage. So, and that actually created a lot of rift between the husband and wife, and the parents of the girl had to bring both the girl and later the boy to the doctor to educate them about how pregnancy can actually happen even with one single exposure to sperm. So that's how educating both the partner and the woman about the family planning, conception, and how, if they are not planning, pregnancy, how to delay the pregnancy. Such things have to be explained to the couple. And research says that when the couple makes informed decisions, the outcomes of the pregnancy are going to be positive. Now, let's talk about evidence-based practices in the antenatal care. Now, these practices from now on, which I'm going to present, are basically taken from the World Health Organization's recommendations. Now, the World Health Organization has come up with the guidelines both for antenatal and intranatal postnatal care for positive birth outcomes. So basically, the content is taken from their site. And now, what does the World Health Organization say about the diet during pregnancy? As already shared, encouraging a healthy lifestyle and healthy eating habits and maintaining a healthy weight by the woman who is expecting or in the antenatal period is very important for having optimal birth outcomes. When we are talking in a country like ours, we come across a lot of undernourished pregnant women. So traditionally, when we see a undernourished pregnant woman, or any, for that matter, for any person with undernourished, who is undernourished, we right away prescribe to them high protein diet. But the research is saying that high protein supplementation in pregnancy is really not going to help in undernourished women. Rather than helping them, it is going to have negative effects. So that is, normally we go with high protein diet, but instead of recommending high protein diet, it is recommended by the World Health Organization to recommend balanced energy protein diet supplementation. So we just not give high protein, but also incorporate the other components of a balanced diet, like the adequate amounts of carbohydrate, fats, proteins, minerals, and everything else. So balanced energy protein dietary supplementation is recommended for undernourished population. Now, coming to another common habit of a lot of us, especially from South India, I think a lot of us consume a lot of coffee every day. So caffeine is not actually safe during pregnancy. That is what the research is saying. Earlier, they used to say that 300 milligrams of caffeine per day. Maybe it could be, the caffeine could be from chocolate, coffee, or Coke and drinks like that. From any source, not more than 300 milligrams per day is what was suggested earlier, because caffeine can cause loss of pregnancy and also low birth weight neonates at the end of pregnancy. But recent research is saying that there is no such thing as a safe amount of caffeine dosage, especially during pregnancy. Studies have found that an intake of caffeine as much as 100 to 200 milligrams per day is also associated with miscarriage, fetal growth restriction, low birth weight, cognitive development impairments, overweight, and obesity in the children later in their childhood days. So it is best avoided during the pregnancy. So we think that only alcohol or smoking is injurious, but even coffee can be, injurious to women when they are pregnant. Yes. Now, talking about the supplementation, we know that in India, we have a lot of women and young adolescent girls who are anemic. 52.2% of pregnant women and 63.2% of lactating women in India are anemic, right? So anemia is the #1 cause for maternal and perinatal mortality. And when the mother is suffering from anemia, the baby also turns out to be anemic. And also there is a high risk of premature delivery, low birth weights in the baby. So to prevent this, we usually prescribe supplementation of iron and folic acid, 30 to 60 milligrams of supplementation of iron is recommended along with 400 mcg of folic acid. And this supplementation has to be continued even into the postnatal period. So we recommend mothers to continue taking iron and iron, especially iron and folic acid, they come in combination. So continue taking it into 6 months into the postnatal period as well. Yes. Then talking about calcium, a lot of our Indian women also have deficient calcium because either they are poor, not able to afford milk products and calcium-rich diets, or it might be because of their dietary habits. Now, a lot of urban women are turning vegans where they avoid milk and milk products. So in such people also we can expect calcium deficiency. But when calcium is deficient in the body, the risk of having PIH increases drastically. Cochrane systematic review that has been done has concluded that there is an increase of 55 to 64% of risk in pregnant women when there is calcium deficiency in the woman. So to prevent this risk, nowadays obstetricians and we midwives also prescribe dietary intake of calcium daily. So usually in the hospitals, they only prescribe 500 to 1,000, but that is not enough. The World Health Organization recommends 1.5 to 2 grams of oral calcium intake every day. So we have to tell the women not to take both iron, because we prescribe both. Tell the women not to take both iron and calcium together because they negate each other's effect. So iron is usually taken with vitamin C in the morning, and calcium we reserve it for taking it after lunch in the afternoons, right? There are a lot of assessments that are usually done apart from the regular routine assessments that are done. I want to specifically bring to your notice about asymptomatic bacteriuria. This is not very well understood or recognized, but asymptomatic bacteriuria is persistent in many of our women. The bacteriuria is so much into the body that they do not have any signs and symptoms. They don't suffer from any clinical signs and symptoms of having bacteriuria. But when tested with culture and sensitivity, you do find bacteria in it, and then you know that they are suffering from asymptomatic bacteriuria. So it is mandatory for all the pregnant women to go through culture and sensitivity. Even though they do not have any signs and symptoms of urinary tract infection, we suggest that they at least once by the end of their third month, 12 weeks of pregnancy, at least once they go in for culture and sensitivity of the urine to find out if there is any asymptomatic bacteriuria. And if it is recognized with culture and sensitivity, a 7-day antibiotic regime is used to treat it. And this prevents premature births, abortions, and also some kinds of fetal anomalies. Now, that's about the evidence-based practices that I wanted to highlight. Now we'll have a brief look at the evidence-based practices in the intranatal care period. Respectful maternity care, this we are hearing a lot nowadays, and the World Health Organization also recommends that women should be treated with dignity, privacy, their confidentiality has to be maintained, and ensure freedom from any kind of harm and mistreatment. Gone are the days where women were instructed to lie down in, supine positions, putting their legs up and, pinching them, beating them, calling them names and, all kinds of things. So it is now strictly, it is never been encouraged, and it has become more into enforcement now after these guidelines have been released, and midwifery breeds on respectful maternity care. So, respectful maternity care ensures all of these women's rights are being met, and it also incorporates a lot of communication between the midwife and the mother, because that is what is going to support her through the basically at the end of the pregnancy. Midwife and the mother almost becomes like friends and family. That is the essence of midwifery, right? So as midwives and as health professionals, all of us do have to ensure that mothers are treated respectfully, and when women are treated with respect, the research is saying that it is going to improve birth outcomes. Certainly, with lots of oxytocin flowing in them, the birth outcomes are going to be very good and optimal. Now, the next thing during the labor as well as in the antenatal period that we should consider is to have a companion of choice. Now, companion of choice here, the woman chooses who's going to be with her through her antenatal visits and with her in the labor and birthing process, right? So, a Cochrane review of 41 articles which mentioned about the companion of choice at birth says that when the woman has a companion of choice with her through her birthing period, it leads to shorter duration of labor, higher rates of spontaneous vaginal births. It reduces the need for cesarean section, and it greatly improves maternal satisfaction and birthing experience among the women, right? Then the next thing that I would like to bring your attention is about the time of admission into the labor ward. Now, the World Health Organization recommends that when a pregnant woman comes in labor, if she is not in the active stage of labor, which according to the WHO guidelines is 6 centimeters of cervical dilatation, she need not be admitted. She can be sent home with adequate instructions as to when to return, right? But in a country like ours, that is not a possibility in all situations. Yes, there are some institutions and hospitals here as well who do that. They send the mother home when she is not in active labor and ask her to come back only when she is 4 or 5 centimeters dilated, right? So this policy, or having her not admitted immediately, also is recommended by the World Health Organization because it has shown to improve the labor outcomes. Because when a mother returns to a familiar, environment of her home, there is a lot of oxytocin that is released. She's in between her loved ones, maybe her husband, a mother, mother-in-law, surrounded by everyone in a known environment. So her anxiety, stress levels are less. The oxytocin levels are increased, and therefore the outcomes of the labor are going to be very good. So as far as possible, if it is possible, delaying the admission of the woman into the labor room is recommended. If this is not possible, what can we do? At least delay the bringing of the woman in the labor into the labor room, because the labor room sometimes it creates a sense of stress and the fear and anxiety in the woman, therefore bringing in about the adverse effects. So if you can delay the taking in of the woman into the labor room until she is 6 centimeters open and allow her to be in her room or in the ward with her family members, or at least with a companion, the outcomes are going to be good. Then the next thing is about assessment of fetal well-being. Usually when the woman is admitted in labor, we do a auscultation and see what is the fetal heart rate, which is a very good indicator of fetal well-being. So the World Health Organization and also the NICE guidance, they recommend that intermittent auscultation of the fetal heart rate has to be done throughout the labor. So earlier it used to be 30 minutes in first stage, and then once the mother is in active stage every 15 minutes. But now the NICE guidance says that throughout the first stage of labor, The fetal heart has to be auscultated every 15 minutes and with after every contraction in the second stage of labor. This will ensure the safety of the fetus. And the baby that is to be born. So this is also another strong recommendation which is done based on the research. This is again a very interesting area of labor and birth, that is pain and relaxation in labor. Women can be offered parenteral opioids like fentanyl, dopamine, pethidine. This is not possible in all situations, especially if you're working in a government area when there is a short staff. This is usually not done, but where there is adequate number of staff and trained personnel to observe the mother and follow, then this can be given as an option to the mother. When pain is not felt, the outcomes of the birth is going to be good, right? Apart from these medicines or opioids and things like that, manual techniques can also be used to relieve pain in the women. Manual massage by the partner or the midwife, application of warm packs or hot water bags on the low back, all these are going to help. And a warm shower, if possible, are going to relieve the pain and relax the mother, which ultimately are going to increase the release of oxytocin and the labor progresses well. Apart from this, if there are trained midwives, these trained midwives can offer the mother progressive muscle relaxation technique, breathing techniques can be taught, music and other techniques like aromatherapy, water hydrotherapy, all these things can be offered to the woman depending upon the availability of the resources. A meta-analysis that was done by Smith on the currently available evidence says that when manual methods are used for pain management, the women have reported reduction in pain scores, shortage in duration of labor, and great sense of control and satisfaction among women. Another important recommendation by the World Health Organization is to provide and encourage oral fluid and food intake by the woman in the labor. Earlier, once the woman is in labor, they used to say, stop eating anything, or even water used to be given very sparsely. But now research is saying that when a woman eats, low-risk women especially, eats and drinks well throughout her labor, it is going to have a very important effect on the clinical outcomes. Now, this is the conclusion of a huge systematic review that was being done. Then another thing we would like to know about is the positions that are taken by the woman in the labor during her labor and birth. A Cochrane review of 19 trials across the globe have shown that women who take upright positions during their labor and birth have shorter first stage of labor, obviously, because of the gravity effect. Their labors are going to be 1 hour, 20 minutes shorter than the women who give birth in recumbent position or non-upright positions, right? They also are contributing to lower rates of instrumental and episiotomies, instrumental births and episiotomies in these women. So in midwifery, we encourage women to be upright, to be ambulatory throughout her labor and birth, and we have certainly seen these things happening right in front of our eyes. When the woman is in the second stage, normally the obstetricians or the nurses, they encourage the woman to bear down or to push the baby out. Even in movies, we see people around, if there are any companions who are with the woman, they keep shouting push, push. But research says this is not a correct one. We should not instruct the woman to push on our instructions. Rather than the woman's body, her itself will tell her when to bear down. We don't even call it as push, we call when to bear down. That is basically because of the Ferguson's reflex. When the fetal head hits the pelvic floor, the reflex comes very naturally for the woman to bear the baby out of her body. That is a natural instinct that happens, right? So the research which has been done in this segment of the labor, where they have compared whether natural physiological bearing down or bearing down on directive bearing down, what we call as, is which of these two is good. And of course, physiological bearing down is found to be more beneficial, because women, when they follow their body and follow the basic instincts, they feel more in control and they feel empowered and are satisfied with their birthing experience. Then let us look at the techniques that are used in midwifery to minimize or to avoid perineal trauma. As midwives, when we are seeing our women in our OPDs, we usually educate them and demonstrate to them on a dummy or on a model how to do perineal massage. This will be starting from 35th week of their pregnancy. So perineal massage, when performed regularly, has shown a very good effect in preventing perineal tears. And the need for episiotomies also go down when the woman uses this technique. So from 35th week, we instruct how the woman can do. Either the woman can do, or her partner or can also help her in doing the perineal massage, where the perineal muscle is stretched using some oil and massaged every day. Right. Apart from perineal massage, warm compress given or applied during the second stage, when the perineum is getting stretched, when the baby is being born, when we use warm compresses on it. And this also has shown to reduce the perineal trauma. And the hands-on technique, there is a lot of debate going in midwifery itself, whether hands-on, that means supporting the perineum using our hands when the baby's head is coming, or just to hands off and just watch the baby come out naturally. But the World Health Organization recommends that we use hands-on, because hands-on technique has shown to minimize the second and perineal tears in the birthing women. So high certainty evidence indicates that perineal massage reduces not just first and second, but third and fourth degree perineal tears as well. And warm compress helps in prevention of first and second degree tears in the women. And also it reduces the need for perineal suturing. Use of uterotronics, again, this is not a new thing. We have always been using oxytocin. In the World Health Organization and also the Government of India recommends active management of third stage of labor. That means once the baby is born, the woman is given 10 units of international units of oxytocin intramuscularly. So this is to prevent the postpartum hemorrhage. In settings where oxytocin is not available, inject other injectable uterotonics such as ergometrin or methyl ergometrin or oral misoprostol can also be used to manage the third stage actively. And all of these techniques or measures will help in preventing postpartum hemorrhage in the woman. Then once the baby is born, the next we have placenta that has to be birthed or delivered. In midwifery, we encourage our midwives to use physiological birthing, because that does not involve physiological birthing of the placenta, does not involve using cord traction. Normally, we do the cord traction and counter traction in our hospitals, but physiological birth of placenta involves not handling the placenta and just putting the mother in an upright position, in a propped up position, and the placenta descends down by means of gravity and comes out. But the World Health Organization as well as the Government of India recommends using of CCT for delivering the placenta. because research has shown that when cord traction and counter traction is used to deliver placenta, the third stage is shorter and also low risk of having woman losing her blood and going into postpartum hemorrhage. So these are the different evidence-based practices we use in pregnant women, both in antenatal and intranatal period. Now, a very brief look at the evidence-based practices in the newborn care. It is strongly recommended that the routine oral and nasal suctioning is not recommended in infants or newborns who are born through clear amniotic fluid. That means suctioning might be necessary if the amniotic fluid is meconium stained. Otherwise, if it is not meconium stained, there is no need of us to do any mouth and nose suctioning after the baby is born. Through the process of the birth itself, the baby pushes out all the fluid that is in the lungs, and once the baby is born, the breath occurs spontaneously, and whatever remaining little amniotic fluid is there, it comes out naturally by gravity within a day or two, and we need not be worried about it. So it is routine suctioning is contraindicated in the newborns. Another important thing that we follow as midwives is a delayed umbilical cord clamping. Normally, once the baby is born, immediately they clamp the cord and cut the cord, which is not at all good for the baby. Rather than that, we practice what is called as optimal cord clamping or delayed cord clamping, which is waiting for the cord pulsations to stop. It usually takes around 3 minutes. And sometimes it might go a little longer, but at least waiting up to 3 minutes after the baby is born, it is very important, because when we do this optimal cord clamping or delayed cord clamping, research has found that up to 80 ml of blood will flow into the newborn within the first minute after birth, and nearly 100 to 120 ml of blood goes into the newborn circulation if we wait for 3 minutes after the birth. So if you are hurrying up and cutting, you are not allowing this amount of blood to go into the newborn. What happens if the newborn does not receive this? The newborn might go into, anemia after birth. The birth weight also is going to go down. So optimal cord clamping is recommended by the World Health Organization, which improves the iron stores in the newborn. It improves and shows a better birth weight, and also the immunity also is improved, and the studies show that it also prevents iron deficiency anemia up to 1 year in the newborns. This delayed cord clamping can also be practiced for women living with or suspected with HIV as well. So we do not need to differentiate. Even with them, we can wait. The next important recommendation is the skin-to-skin contact. This is a very beautiful procedure, I should say. The moment the baby is born, we put the baby onto the mother's tummy, dry the baby, and put on the mother's tummy. Now, this we call as skin-to-skin contact. And skin-to-skin contact is a very powerful vagal stimulant, because with the sensation of the baby touching the mother's skin, the warmth and the smell of the amniotic fluid, it is going to release an additional amount of oxytocin in the woman, which decreases maternal anxiety, increases her calmness, and enhances her parenting behavior, as well as it also helps in preventing postpartum hemorrhage and causes the uterus to contract well after the baby is born. Now, this oxytocin that is released inside the mother also increases the skin temperature of the mother, especially around the breast area. That is the reason why we put the baby on the abdomen, and the baby slowly crawls up onto the mother's breast and latches onto the mother's breast. So it provides that warmth that the baby needs. In fact, a research, thermographic research that was done by Tristidis has found that placing the baby on mother's skin is as good as placing the baby in a radiant warmer. That much of amount of heat is generated in the mother's body once the baby is put on the mother's abdomen. So it also initiate early contact, bonding is improved, and the baby also starts breastfeeding, which is going to be continued into. So skin to skin contact has got a lot of advantages, both for the mother as well as the baby. Now, other newborn practices, care practices that we speak about is delaying the birth of baby. Earlier, we used to see that the babies in the labor room used to be cleanly wiped off the, all the skin, and they were washed under the taps and put in water tubs and washed. But that is not recommended. So delaying the first bath for 24 hours is recommended. If it is culturally not possible, delaying it at least for 6 hours is recommended. And rooming in of the mother and baby all through the 24 hours of the day is strongly recommended, because that increases bonding and improves the breastfeeding rates, and also improves the immunity in the newborn. And administration of vitamin K is done to all babies who are born with a birth weight of 1.5 kg or above. 1 milligram of vitamin K is given intramuscularly. This can be delayed up to first hour. In the first hour, the baby and the mother, the diet of the baby and mother is not disturbed. They're just allowed to rest, relax, and bond. If at all this vitamin K administration has to be done, or the weight of the baby has to be checked, it is usually done after the first hour of the birth. So they will say that wait for weight. You don't have to hurry up for that. So those are some of the intranatal care practices. Now, quickly looking at some of the important postpartum care practices for optimal birth outcomes. It is observed that 40% of neonatal deaths occur in the first 24 hours of life. This is usually because it is related to asphyxia related births, and three quarters of them are asphyxia related births. So that is the reason why the woman and the baby are usually kept in the healthcare facilities at least for 24 hours. Here in Telangana, our women after their normal births are kept at least for 48 hours. If there is need, the stay is extended. But the World Health Organization recommends that to have optimal outcomes in the newborns and to preserve their life, keeping them in the healthcare facility and observing them, monitoring them for the first 24 hours at least is very important. And yeah, about the postnatal follow-ups, not many people actually come for postnatal follow-ups. And research has found that 2/3 of neonatal deaths occur in the first week of their life, which is because also related to lack of postnatal follow-up. Now, what happens is when the mother comes for a postnatal checkup for the first postnatal checkup after she leaves for home in the first week, she comes back with the baby. So it gives an opportunity for the midwife or for the doctor to also examine the baby if there are any danger signs, to identify them and treat them accordingly. So when the first postnatal visit does not happen in the first week, there are chances of the newborn getting into serious situations, and even neonatal deaths can be occurring. And after the first postnatal checkup in the first week, a second visit is recommended around 6th week. Both of these are considered to be important, and also important in reducing sudden newborn and infant deaths. So research also validates this point, that postnatal visits are a must for the women who give birth in the hospital. So these are some of the evidence-based and research-based, practices that we as midwives and obstetrical nurses are carrying out for optimal outcomes. So in conclusion, I would like to say that all of us have to keep abreast with the evidences and follow them without compromising anywhere. and practice the recommended guidelines. There are a lot of guidelines even available for us. We have the Government of India guidelines, Lakshya guidelines, some of the care aspects we can also find in them. So practice, put to practice all these guidelines, which is our fundamental duty. And evidence-based practices are for us to put in our clinical practices and also in our clinical teaching practices. Now, most of us being nursing teachers, we do a lot of clinical teaching. So incorporate those into the clinical teaching, which ultimately are going to lead to, better maternal and fetal outcomes. And this will, in fact, help us move a step forward towards, achieving our maternal and infant mortality, morbidity rates, reduction in them, and ultimately yielding optimal outcomes, which are, our priority. So let us all keep these things in mind and try following as much as possible. So these are my references, and thank you all for giving me this opportunity once again, and I'm open for any questions.
Thank you so much, ma'am, for this wonderful session.
Thank you.
Ma'am, one query is there. Nowadays, vitamin D3 administration in newborn by many neonatologists. Can you please elaborate this?
Vitamin D administration in the newborn, is it?
Yes, ma'am.
Normally, this is not a recommendation that is given by the WHO. I think, exposing the newborn to adequate sunlight is just enough to take care of their, vitamin D and calcium requirements. And if the mother is having adequate amounts of D and calcium in her blood levels, it is going to go into the baby. So normally, newborns do not need any supplementation as such. If at all there is any pathological condition and if it is prescribed by a neonatologist, then it is a yes. But normally, normal newborns do not need any supplementation. That's why we say exclusive breastfeeding for 6 months, not even any supplements are given, at least for the first 6 months.
Okay, thank you so much, ma'am. This was so excellent.
Madam, ma'am,
Yes,
there are
ma'am.
some questions in QA box as well. You can take those queries. QA box.
Okay, I will check, ma'am.
Yes, sure.
Yes, ma'am. What is the dose of aspirin in pre-eclampsia women, and when to start the low dose
Yeah.
aspirin?
Right. Aspirin is again prescribed by some obstetricians as a preventive aspect for preeclampsia, along with the calcium supplementation that we give. Usually, they give a low dose aspirin of 75 mg once a day. That is the dosage that is advised. Midwives do not advise this. This is only advised by obstetricians.
Okay, ma'am. And in the labor room, what is the nurse-patient ratio?
Nurse-patient ratio. Basically, being a midwife, I don't call my women patients. So we call them mothers. It is actually one-on-one, but according to the Indian Nursing Council, the nurse labor room table ratio is 3:1 table. That is the ratio that is given by the Indian Nursing Council.
Okay,
But
ma'am.
in midwifery care, it is ideally it is one-on-one. So the midwife stays continuously throughout the labor, at least for the shift duration that she is, and then next midwife takes over in the next shift. So it is 1:1.
Okay, ma'am. So one more question is there. How ABO incompatibility can affect subsequent pregnancies, just like RH incompatibility?
Right.
Do we...
Actually, even there is a recommendation by the World Health Organization, which strongly advocates for, that immunization for this RH incompatibility. Yes, the first pregnancy definitely escapes. And for the second pregnancy, as a preventive measure, immunoglobulins are administered. They can be administered immediately in the first postnatal period. That means once the mother gives birth, it can be given in that particular postnatal period itself as a preparation for the next pregnancy. If it is also advocated that it can be given in the antenatal period, even for the first pregnancy by the World Health Organization, it is given somewhere between 28 to 32 weeks of pregnancy. It can be given, and it is advocated.
Okay. And what is the present scenario of midwife lead care in Telangana?
Yes, I think we are the first nation to start midwifery practitioner course, and we have thus far trained almost 354 midwives in 4 batches, and we are going to get another batch very shortly. So we have lot of midwives. They are trying to practice what they have learned, but I should say it is not very ideal. But my girls are doing their best to do, they're working in what do you say, as optimal conditions. They're trying to bring out best of what they have.
Okay, ma'am. Next is the fundal pressure
Challenges as well.
pressure is fundal pressure practices encouraged while mother delivers the baby?
No, it is an absolute no. It is a breach of respectful maternity care. It is practiced by many obstetricians and they think it is normal. It is correct, but no, it is a no. There is a lot of evidence against, applying fundal pressure. It leads to postpartum hemorrhage, uterine damages, deep, injuries, and fourth-degree perineal tears, and the mother is scarred for her life emotionally. So it is an absolute no. It should never be used.
Okay, ma'am. If a 2 to 3 months baby spits up a lot of milk, what do we do?
It spits up a lot of milk.
Yeah.
Basically, that is a routine thing for some babies to spit up the milk, little amounts. But if the weight of the baby has to be monitored in such cases, if the baby's weight is not increasing, that means the nutrition is not going. That means a baby has to be evaluated for further abnormalities if there are any issues with the sucking and swallowing. And we also can actually examine if there is any cleft lip and cleft palate and the baby or nipple issues of the mother. The baby is not able to hold the nipple properly, and maybe because of that, it's just leaking the milk out when it is sucking or spits out. There could be any reasons. It has to be thoroughly investigated.
Okay, ma'am. And methargin is completely banned during second stage of labor. Can you explain about methargin?
Methargin is not banned actually. Because of the side effects it can have, methargin is sparingly used. Methargin is used in the management of postpartum hemorrhage. Methargin can be used in women who do not have any heart and blood pressure issues. So if they have any heart problem or blood pressure during pregnancy, we don't advise or we don't give methargin to, because it increases the pressure again and can lead to fits or eclamptic fit in the mother. So we avoid using methargin in certain conditions. But if the mother is not having any heart issues and blood pressure issues or asthma, methargin can be given, and it is not regularly given now, and used sparingly as a management of postpartum hemorrhage medicine. Now that oxytocin is readily available, we are giving oxytocin mostly for third stage active management.
Is the hot application increase the progress of labor?
Hot application does not increase the progress of labor, but in a way, not directly. It relaxes the muscles. When the muscles are relaxed and when the woman is relaxed, it secretes more amount of oxygen. Oxytocin is the one which is driving the labor faster and more effective contractions. Therefore, the duration of the labor is short. So it is not a direct effect that hot pack lagao ki cervix खुल जाएगा. No, hot pack लगाने से what happens is like the mother relaxes, oxytocin is released in her body, and that propels the labor ahead.
Thank you so much, ma'am, for this wonderful explanation, and your session was so uh,
Thank you very much.
wonderful.
It's a
Thank you
pleasure,
so much, ma'am.
actually. Thank you very much. I thank the organizers and the executives and the office bearers once again for giving me this opportunity. And I hope I was able to convey what I wanted to. Thank you for having me.
Thank you, ma'am.
Seriously, ma'am, it was a wonderful session we had on midwifery, and by so much queries, it came to know that we can conduct much more sessions related to midwifery practices.
Okay.
Actually,
You're
it is the
welcome.
demand of our, participants, ma'am.
Oh,
Thank you so much, ma'am, for a wonderful session you had.
thank you, ma'am. Thank you for having me.
Over to you, Madhuri, ma'am.
Ma'am, can I give the vote of thanks now?
Sure.
Okay. So, ladies and gentlemen, esteemed guests and honored speakers, I would like to take this opportunity to express our heartfelt gratitude towards Dr. Farooq Khan sir, founder president of NTI, Neeraj K. Swankar, former president of SOCN, and Miss Danny ma'am and Miss Jyoti Shina ma'am from SOCN, Dr. Poonam Thakur ma'am from NTI for their invaluable contribution and their support. I extend heartfelt thanks to Dr. Ruth Joshila Phillips ma'am for sharing her expertise and insights. I extend the token of gratitude toward all the NTI and associate members for their tireless efforts in making this event a great success. I appreciate CBS publishers for their generous support. We are really thankful to everyone who participated for your active engagement and enthusiasm. Thank you all for making this webinar a memorable and enriching experience. We appreciate your presence and look forward to future collaborations. Thank you so much.
Can we leave?
Yes, ma'am. Of course, ma'am.
Thank you. Thank you very much.
I think the session is over to Nursing Next Live. I can see in the chat box, as many of you are asking about the participation certificate. Those who are attending the sessions for the full time, they will be receiving their certificates by CBS publishers soon. In case you have attended the whole session and you are not receiving your certificate, you can directly drop message to us also. Thank you everyone for your participation.